Hello, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Rorak Hooten, who is a pulmonology and critical care physician at Monument Health. Doctor, thanks for joining me on this podcast.
Thanks for having me.
I'm so excited to talk about robots here in a second. All right. Now you're local, East River, but you're local, right?
Correct.
Born and raised here. What put you on this path, Doctor? When you were in grade school, high school, did you know this was where you were going to end up?
Kind of. I initially started thinking I was an athlete in high school and college. I ran cross country and track, both in high school and college. And so I wanted to work with athletes, so I thought. And then so I was going to do, physical therapy and sports medicine type things. And the more I studied and the more I just wanted to go deeper, and so that's what ultimately led me into being a physician. How do I get to pulmonary and critical care?
Yeah, that's a big jump from a physical therapist to, operating on people's lungs.
Yeah, so the very short version is we sit in internal medicine, and you have to know everything about everything in the body.
Right.
And the intensive care unit was kind of the place that really attracted me. It's kind of everything, and it's intense, and it's fast moving. And that was a lot of fun when I was training. It was the place where I got a lot of satisfaction. Pulmonary kind of goes hand in hand with it because a lot of patients that are sick in the intensive care unit are on a ventilator or need, we're breathing for them.
Right.
And so that easily kind of lends itself into the lungs. And so the two go hand in hand. As time has gone on with my career, I think the ICU is still fun and fast-paced, but it's fatiguing.
Oh, do you so you still do some ICU work then?
I still do ICU. In fact, I was in the ICU last week.
Oh, boy.
And so when I'm not in the ICU, it's kind of a nice break to be on pulmonary. And it's really a different challenge. Some of the pulmonary diseases present differently and have different challenges, and it's hard sometimes to figure out what's what.
Right. Well, that will lead us into, I think, what we're talking about here, and a piece of equipment that just watching the videos of this today, growing up, I was a huge science fiction fan. I loved all the sci-fi movies, and you'll always get those certain scenes of somebody being hurt and going to to the doctor and the equipment that they had in the sci-fi movies, and you wonder if one day you'll ever see that, if that's even possible. And then you watch the stuff that's coming out now, and we're there in certain instances, right?
We are.
There's the topic for this podcast is the Ion lung biopsy robot that works. It's not only used for lung cancer, is it?
I would say that it's used to take very precise biopsies. And so most of the time we are talking about nodules. Is this lung cancer or not? But I have had many cases where, sometimes we'll have weird infections or we'll have some kind of weird growth that we don't think is cancer, but we need to figure out what it is. And so we need to have very direct biopsies.
So how did this, before this type of equipment came about, and speaking of this, your training leading up to all of this and the technologies that you had, getting something like a legitimate robot to help you in the operating room, it's exciting, but it has to be really challenging to learn this stuff as this technology happens so quickly, doesn't it?
A little bit. I also think there's a sense, the robots are really amazing, but I remember the first time that I heard about this as a thing.
Right.
It's kind of like, well, I don't really need a robot. Like, I'm pretty good. It was obviously an arrogant, naive thought at the time until I got my robot, and then it's like, wow, this is really amazing.
Did you ever think you'd say the sentence, until I got my robot?
No.
That's so how did it work when you go from what I understand from this particular piece of equipment is it allows you to go to almost every part of the lung in order to find these nodules or these problems, right? So before that, how did it work before this type of equipment came along from the time you started?
So I would say we should contrast this a little bit with, kind of a manual
Okay, yes,
bronchoscope.
perfect.
And so we still use those in every robotic case.
Okay.
But the limitation with the robotic scopes is the thickness of the scope. And so it will only go so deep before it's problematic. It gets stuck.
Okay.
Because the airways get smaller and smaller and smaller. And so the robot is much smaller. And that's part of the robotic piece, is that to control it appropriately, it needs to be fed by the robot, not my manual, aggressive. And so manual bronchoscopy has been around for years, to the point where they were, looking through an eye scope to see down there. We don't do that anymore. We have videos.
Good.
That said, that was kind of the initial. And there are smaller scopes, manual scopes, that you can get out pretty deep into the lung, but it doesn't integrate all of the mapping and things that we'll kind of talk about. The second piece of this, and really kind of the second robotic part, is the navigation. And so the navigation piece kind of helps you decide, where do I need to go? And you can do that manually, but that's really, really tough to do.
Yeah.
Look at a CT scan and say, I need to turn left here and right here and up there and down, particularly when you're out in the lung, because you have no waypoint to say, is this the right place?
Right.
The idea of navigation has been around since I was in training in med school. Kind of the old school ways that we did this is that you would get a sensor, a magnetic sensor, electromagnetics, and you would put a pad on the front of the patient and a pad on the back of the patient, and then between those sensors it would detect where the scope was. And when it worked great.
So it was kind of blind almost, in a way, wasn't it? I mean, yeah, you didn't really have what this thing can do, obviously.
The problem with electromagnetics is that it interferes. I mean, X-ray interferes with it.
Oh, sure.
And the other part is that the lungs are dynamic, right? You have to breathe.
Right.
All the time.
Yeah, you can't shut them down to see where you're going. Oh, never even thought of that.
And so there was constant movement no matter what you did. And so the electromagnetics, like I said, when they worked, which in my experience was about a third of the time, it worked great.
Yeah.
And the other 60% of the time, you're frustrated.
So looking at some from start to finish on this. So somebody comes in, I'm assuming it starts with maybe chest pain or trouble breathing or throwing up or things like that. I mean, is that
actually most patients are asymptomatic when they come to us?
Really?
Mm-hmm.
Then how do they know, or why do they come in, or you find it looking for something else?
Sometimes.
Okay.
So there are a number of reasons that patients come in. So lung cancer or lung nodules, I would say most of the reason people come to us is they have a lung nodule.
Right.
And so what is a lung nodule? Well, it's this little growth in your lungs that can happen for a lot of reasons. In fact, most patients that have lung nodules, they're completely benign.
Okay.
If you were to scan somebody in their 60s or 70s, like 70 or 80% of people will have a small nodule or two. It's because you get pneumonia as you interact with the world, you breathe things in.
Right.
And so it gets in there and kind of festers and creates this scar tissue. Lung cancer, though, can look the same way in the beginning. And so we have to figure out, well, who's who has this benign stuff and who has the lung cancer. And so smoking plays a huge role in lung cancer, obviously. And so there are screening recommendations for patients that have smoked 20 years, age 50, 20 pack years.
Okay.
Over 50, you should have a screening CT once a year. X-ray's not good enough. X-ray, just a flat plate X-ray, isn't good enough because it's not detailed enough.
Right.
And so CT scans often pick up those early. And so at that point, we can sit there and watch them. And if they're growing or changing or a certain size, we then take those characteristics, say, hey, this doesn't look normal. We need to go in there and biopsy and figure out what it was.
Right.
Not every nodule needs to be biopsied. Like I said, if you don't have those other high-risk characteristics, we can say, well, let's just watch this on imaging. It's going to grow slowly, or it's not going to grow. And then we don't need to it's benign. We don't need to worry about it.
Does a lung cancer generally grow slowly, or can it be pretty aggressive?
Generally, they are pretty slow.
Okay.
Usually over the course of months to years. There's one variety that does tend to be more aggressive. It's highly associated with smoking, and it's common, but not the most common.
Okay. So somebody comes in and you see something that's a little bit worrisome. Then what's the process? How does it begin until you get to the robot?
So they come in and see us, and like I said, if it's the first time they've ever had a CT scan, depending on how big it is, so things that are less than a centimeter, we might watch. We might say, we're going to do another scan in 3 months, 6 months, a year, etc. If it's more than a centimeter, I start to get concerned. And so people think centimeter's not very big.
Right.
But you get to the point where you have like a 3 centimeter growth, and the likelihood that that's cancer is really high.
Okay.
And so at that point, we would decide, okay, we need to figure out what this is. And so you kind of have 2 options. Number one is you could go do what's called a PET scan. And the PET scan will show you activity, metabolic activity. And so if it lights up on PET, it doesn't really help us. It says you have to biopsy this.
Right.
And so I don't often do PETs unless we have concerns about the biopsy or the location or something. The easiest way is just to go to biopsy.
Okay. So once you notice that you have to do something like that, and you turn to the robot, right? Like we said earlier, what this robot allows you guys to do now is to get almost all the way into every part of the lung. Why is it so? Why has it been so hard to get out to? Is it kind of the outer part of the lungs that are hardest to get to?
Generally.
Why has that been so difficult?
So the hardest places to reach in the lung really are the outer components.
Right.
And it's because to do it from the inside, you have to follow the body's network.
Okay.
Right?
Yeah.
The airways.
Right.
And the airways, particularly as they get further out, become more floppy and they collapse, and they're hard to see on CT scan. And like I said, they're really small.
Yeah.
Really, really small. And so the robot now allows us to do better mapping. And because it's smaller and can control more precisely, allows us to get much deeper than we could ever get before this.
So I noticed something as I was watching the robot, something that spun around the body. Is that part of the mapping with that as well?
No. So during the procedure, we actually use X-ray.
Okay.
Particularly when we're actually taking the biopsies. And so it helps us to decide how far we stuck out the needle and where exactly we are.
Okay. So there's the tube that goes in, does it always have the needle on the end of it? The flexible needle?
No.
Okay.
No. Maybe we should back up a step.
Sure.
And so let's say you've decided that we need a biopsy and you want to do it via the robot.
Okay.
Okay, because there is another way you could do this. The way we've been doing this up until then was that you would lay on in a CT scanner, and they would take a needle and come from the outside in.
Okay.
Okay. And we still do that. There are cases where we have to do that.
Right.
The robot just it's not the best biopsy.
Yeah.
Okay. And we have interventional radiologists that are really great and exceptional here. They do a lot of them. But the problem is that the lung is essentially a big balloon.
Yeah.
And so if you stick the balloon, what happens?
What will go wrong, right?
It pops. And so about 10 to 20% of the time, depending on who you're reading and what needle and all of that stuff, the lung will pop and leak out, and then they have to stick in a chest tube and suck all the air out so the lung can heal and re-expand. That can still happen with the robot.
But the robot goes down your throat.
Right.
Oh,
so the robot
okay.
comes from the inside and
Right.
going towards the outside. And so for biopsying on the outside, it's still possible, or towards the outside, it's still possible that happens.
Right.
But the risk is only about 1 to 2% versus 10 to 20.
Boy, that takes it way down, though.
Yes.
So, okay, and maybe this will be a silly question. Maybe you've kind of answered it, but why not use it for every single biopsy that needs to be done, since you're not directly poking the lung from the outside?
So we're using it a lot more.
Okay.
The robot's not perfect.
Okay.
And so sometimes the turns are really tight, too
Yeah.
tight for the robot. Oftentimes that's not something we can predict ahead of time. The other thing is that people that have smoked a lot and have a lot of emphysema, so emphysema is essentially damage to the lung, right? And so sometimes the airways to get out to that area are so damaged we can't get there.
Okay. So do you see down the road for this, do you see other ways this can be used outside of just the lungs or for just respiratory issues in general? Are there new ways or ways that you think, you know what? What if we tried this with that thing? Is that do you guys have discussions like that?
Some.
Okay.
I think what we're doing with it right now is really for diagnostics.
Okay.
It's about figuring out what's what. The treatment down the road is something else right now.
Right.
It's radiation. It might be surgery. It might be something different. I think the next phase of this and the thing that we'll see in the next 10 years is that they'll start focusing on therapeutics, that we may be able to take the nodule, get our biopsies, and then shortly after, for lack of a better term, neutralize or treat the nodule.
Like right there.
Right there.
Okay.
I don't think we're there yet. We have a lot to learn.
But this happens so fast, doesn't it? I mean, even 10 years down the road, when you go back 150, 200 years, that change it has to be exciting for you guys with what's coming up, right?
Yeah, I mean, medicine changes very quickly.
Right. What types of patients are typically needing this type of procedure?
So most of the time, it's smokers or former smokers.
I want to let people know we just can't stress that enough, okay? Smoking causes more problems in every part of the body than I think people realize. So, of course, smoking, yeah.
And especially the lung. And so, like I said, majority of our patients are smokers that get these. I have had others, though, that don't. Like I said, we've had some that have kind of weird-looking infections, and so we'll take the robot and go out and biopsy. And so in that case, we're looking at the tissue, but also doing cultures and trying to get other bugs to grow to figure out, well, which antibiotics should you be on.
Right.
But I would say probably 90% of the time we're looking for cancer, and I would say the vast majority of our patients are smokers.
So, okay, so let's taking smoking out of this because we should know, every single one of us on the planet right now, that this is not something you should do if you want to be healthy. What other ways can you protect your lungs? I mean, outside of stuff like that, we'll always have the air quality issues and things like that will affect certain people differently. Genetically, not much you can do about that, I suppose, either. But are there things that we don't think about that we can do that can protect our lungs too in certain situations?
Honestly, the biggest protection for your lungs is to use them.
So exercise.
Exercise.
Fill them up and use them.
Yes.
Okay.
And so it's interesting. People come into the clinic and they have various lung diseases, even emphysema or COPD from smoking.
Right.
And they say, well, I can't do a lot. I get short of breath. That's correct. But most of the time I can't fix what's going on in the lung. What we can do, though, is we can help your heart and your muscles to be more efficient, and the only way you do that is to move, to exercise.
Right.
And so some of my patients come in and initially are, use their breathing as their excuse not to be active, and I kind of tell them you can't do that. I mean, there's a fine line, right?
Sure. Oh, absolutely.
You can overdo it.
Right.
I'm not saying they need to go out and start running marathons. That's not going to happen. But if you come in and all you can walk is a block, then you need to walk a block every day until you can do more.
Right. So is that probably one of the best types of exercise, like walking, brisk walks, running? Is that probably one of the best ways to keep your lungs healthy?
So aerobic activity is probably the best.
Okay.
Yeah. And you don't have to run. Walking
Right.
is sufficient. It takes longer, yes.
Yeah.
But you do what you can.
Right.
But there's also some evidence that even just doing simple weight training. And so, a lot of our patients that come in are older. They've smoked in the past. They're in their 70s maybe. And so I tell them, you don't have to go get a gym membership. You can walk. You can go to the malls and walk in the winter as winter comes. I also tell them, like, hey, if you just did some simple exercises, you can do them with soup cans. Like, you don't have to have weights. You don't have to. And really, your body will stay in okay shape. It's not going to be a bodybuilder. That's not what we're asking for.
No, exactly. It's just a healthy lifestyle. It's just a way to make sure that when you do hit the 70s and 80s, maybe you won't have as many issues then, right?
Correct.
Okay. Dr. Rorak Hooten, pulmonology and critical care physician from Monument Health, thank you for coming in and talking about this. I appreciate it, doctor.
You're welcome. Thanks for having me.
You bet.